Good afternoon, everybody. Thank you very much for holding on. I know all your blood glucose levels are extremely low right now. Mine is, I know that. Thank you, Madam Chairperson, for letting me go next, and for the excellent speakers who have preceded me. I know I will not be as brief as Dr. Sonal, and I will not be as extensive and comprehensive as the radiologist colleague who just talked. But I want to tell you something new. I think you may not have heard what I'm going to tell you before. So maybe just wake up for 8 minutes and watch for just what I'm going to tell you. I'm a pulmonary and critical care physician. I was in the US for 15 years, moved back about a year ago to India. And fortunately, I've come across something very interesting, which is Tele ICU. And my talk is going to kind of focus on what this holds for the future for India. And I think this is going to be a force multiplier for taking care to the last mile of the rural Indian. It's going to be taking specialty care to almost everybody in this country and maybe beyond. The future, is really ICU, and it's just a pun on the word ICU, because the video conferencing facilities that we have right now really help people with taking care of patients remotely. I would like to say hello to those who are watching on the web. I do know that there are people watching on the web. I got some emails on that, so hello there. Thank you for watching. And what I would like to tell you briefly is that critical care really is a large field. I'm sure, and I hope none of you ends up in an ICU. You're not somebody that you want to meet me in the hospital. We can be good friends, but don't see me as a doctor, because you have to be really sick to see me. And a critical care unit is defined as a place where you have specially staffed physicians, specially staffed nurses, special equipment to take care of patients who are extremely ill. Imagine this is a fracture you're trying to fix in a few days. And this is like the human body is fractured, you're trying to really take care of all the vital parameters in an intensive care unit. Intensive care units are, they provide an extremely high level of functioning. They're extremely expensive, and as I'll show you the statistics very briefly here, there's a big demand for ICUs in India especially. The supply is not as much. There are quality issues, there's accessibility issues, there's availability issues. There's an organization called Indian Society of Critical Care Medicine now, which has started recently. It has over 6,000 members. There are specialty ICUs, and there are all-purpose ICUs. There's different kinds of intensive care units where patients can be taken care of. As you notice, I'm doing high-speed talk, just like high-speed rail, so just try to bear with me. And there's some data which is out there. There's a lot of facts which we gather from the West, but fortunately in this field, there is some Indian data out there. And the ICU in India, there are some good studies out there which have shown what exactly is the current status of the Indian ICU. One of my colleagues and partners in one of the companies we run is Dr. Ramakrishnan, who's actually in the audience. He runs the Indian Society of Critical Care Medicine, and he actually published a study talking about the cost of intensive care in India. And the cost is quite a bit. There are about 70,000 ICU beds in India at this time, about 50 lakh admissions or 5 million admissions per year. There is, however, no money. 80% of investment in ICU care is in the private sector, 80% is paid for by the patient, 40% actually sold their assets or borrowed money to get into an ICU, and very unfortunately, at 2 weeks of time, most patients go home. Either they're alive or they're dead. They're dead because their illness got them or because they couldn't pay for their care. Very unfortunate but true statistic. One episode of illness pushes about 2.2% of Indians into below poverty level. And the initial cost of care is what's extremely high. And it is cheaper than the West, probably because of labor costs, supply costs, and the re-sterilization that we do in India. The disease burden in India is a little different from the West. It does include tropical diseases, seasonal diseases, disasters, epidemics, trauma, as was spoken by the earlier speakers. And there are challenges. There are the 5 E's, I call them. Equipment challenges, expertise challenges, efficiency challenges, economics, and ethics. Ethics is very important because doctors in India are losing ethics. Unfortunately, it is a true statement, and it does not miss the critical care unit. And all these factors are really affecting the care that the common Indian is getting in the sickest time of their life. Critical care is expensive care, like I mentioned. Average about 3,000 rupees per patient per day many years ago, much higher now. In the US, it is not too different. There are about 6 million patients get admitted. 10% of hospital beds in America are ICU beds. About 30% of the hospital cost is in the ICU, and over 50% of ICUs are in small hospitals. That's a cartoon from Atul Gawande's very nice article in the New Yorker magazine, which really describes what an ICU involves. I'm getting somewhere with all these facts here. You'll see in a minute or so. There's something called the Leapfrog Group. The Leapfrog Group is an organization in the US, which is a group of extremely large employers who have a lot of patients. About 30 million patients are paid for by insurance companies to the Leapfrog Group. And they went and said, we need better ICU care. And their solution, their treatment was the doctor. The doctor is the prescription. You need a better system of taking care of patients in the ICU. We need more intensive care doctors. Unfortunately, there are not that many. It takes a lot of training to get an ICU doctor. And there are not as many, not just in the US, but even in India, there's not enough ICU doctors. So I think telemedicine fits in here. Why does that fit in? Because why is telemedicine important in critical care itself? We're talking about patient safety. If you have a hospital which has a telemedicine ICU, you can really talk about patients who can get a safer level of care. You increase the quality. The hospital's reputation goes up. You build relationships with remote hospitals. The small rural hospital is now tied up with a big hospital, and the rural hospital may not have to transfer the case. They can take care of the patient right in their own hometown. You also have redundancy, where if the home doctor has to go away on vacation, the Tele ICU person can take care of the patient, and resource utilization can be improved. That's a quick picture snapshot of what this involves. You have multiple monitors where you look at the patient continuously, and there's a supply-demand gap, as you can see on the left side, where there's the optimal utilization and the actual effective supply of critical care doctors. And the right slide shows you the number of Tele ICUs in the US. There's about 41 centers or so where they take care of about 6,000 ICU beds in the US at this point. Now, those are the different centers in America which are having actually command centers for ICUs. There's good evidence for benefits of intensive care in the US at least, where you have a decreased level of care, a decreased length of stay, and improvement in mortality actually. Can we do this from India? The answer is yes. I am actually part of a group that is taking care of patients in America sitting in India. The fact that this involves really a broadband connection and an extremely sophisticated process where you make sure that trends in patient care are monitored regularly. You also have data showing that Tele ICU care can save lives, it shortens ICU stay, it saves money, almost $10,000 per patient, and you actually get more efficient because the community hospital can see more patients at this point. The benefits, again, it decreases your carbon footprints. Patients don't have to drive away from the rural area to the big hospital. There's a large study which came out in JAMA, the Journal of American Medical Association, last year, which actually showed that mortality improves, the length of stay improves, and the patient workflow is slightly different. There are, of course, challenges. Now, the staff may say, we don't want to be seen by other doctors from somewhere else. Patients may not want it. There may be cost issues, and hospitals may not be able to afford it. Power supply may not be there. However, despite these challenges, telemedicine is here to stay. Tele ICU is the next frontier. AICU is a company called Advanced ICU Care based out of the US. This is a company that has set up a branch in India, and we are part of this branch, and we actually take care of US patients in India. Early adopters are examples of this company I mentioned. The other company which myself and my colleagues have started is called 24/7 Health Vision. And Apollo Hospitals, Fortis Hospitals, and it looks like other hospitals including Max and Narayana Hrudayalaya have all embarked on Tele ICU models. The structure of a Tele ICU involves having the technology piece, having the right people. You need a manager, you need doctors, you need the patients also to take care of this. And of course, money is the bottom line, where somebody has to pay for this. And wherever there's money, there's lawyers not too far behind who want to make sure the legal rules are met. Who pays for this kind of a system? It might be the patient, it might be the third party, it might be a hospital, it might be one of us. Taxpayers may decide that, this improves care, maybe we should pay for this ourselves. And that might be where we're heading in the future, especially if we do not have enough doctors to take care of sick patients. Future directions involve technology innovations. Indigenous products, like our colleague from AIM spoke, we can make these things in India. iPhone smartphone monitoring. There's a company called Airstrip, which actually Bluetooth live feeds monitor data directly to your smartphone. Data analysis. IBM had a little ad where they're actually analyzing one neonatal ICU patient. They're getting 43 million data points in a 24-hour time frame. And they're analyzing that to see, are there any trends in this? So there's all kinds of large data set analysis, all kinds of new information coming out with research in Tele ICU. I think the next steps are to explore the frontiers of acute care telemedicine. I think we are seeking willing partners who want to pilot with us, who want to try this in the public or the private sector. And we really want to catalog this journey, because this is not an easy journey to take, and we really want others who follow behind to have a roadmap to follow. Because ultimately, we're all doctors, and this is all about patient care. Ultimately, we exist because of patients. And if the patient's lives and the patient's care can be improved, that's really all that matters. Can we do this for India? I think it's a resounding yes. And we have formed a company called 24/7 Health Vision. And we're trying to take this forward, where we'll help with the process of actually taking care of critically ill patients around this country and the subcontinent by developing an efficient process which really simplifies healthcare and simplifies critical care around the world. Thank you very much. That was a quick speech. Thanks for paying attention.